Welcome to the podcast of HemaSphere, the official journal of the European Hematology Association. HemaSphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
Hello and welcome to the HemaSphere podcast. My name is Charles de Bock and I'm your host. The use of immune therapies in the treatment of B-cell acute lymphoblastic leukemia has really revolutionized therapy. This is not only for therapies such as CAR T-cell based therapies, but also bispecific T-cell engagers, or also known as BiTEs. The first of these was actually approved way back in 2014 and is called Blinatumomab, or often just referred to as Blina. So what is Blinatumomab or Blina? Well, it's essentially an antibody-based therapy, but unlike monoclonal antibodies, these BiTEs have two single-chain variable fragments arranged in tandem. And one of these targets an antigen on T cells, often CD3, and the other one targets an antigen on BALL cells, in this case, CD19. And when BiTEs are administered, they bring the T cells close enough to the BALL cells so they form an immune synapse, activating the T cells to release cytotoxic molecules such as perforin and granzyme B, and these target the BALL cells, resulting in their lysis. And to date, Blinatumomab has demonstrated excellent efficacy in a relapse refractory setting, as well as MRD positive, CD19 positive ALL. And so a number of groups internationally are now beginning to explore whether Blinatumomab can be moved to an upfront clinical setting. And on that note, I am delighted to be joined by Associate Professor Matthew Greenwood from the Faculty of Medicine and Health at the University of Sydney, and also staff specialist at the Department of Haematology and Transfusion Medicine at the Royal North Shore Hospital in Sydney, who is the senior author on a new paper now published in HemaSphere, and this is titled Blinatumomab and de Novo AYA-ALL, Results of the Australasian Leukemia and Lymphoma Group ALL09 SUBLIME Study. So welcome, Matthew.
Thank you for having me, Charley.
I'm going to, first of all, thank you for being in the same time zone as me, because I don't have to be in the middle of the night, which is fantastic.
Unique experience, I'm sure.
Unique experience. It's good. And you can see, for those who are looking at the video, it's actually daylight outside rather than the middle of the night for me. So the first question I really have is about the rationale of your study, or the SUBLIME study, which stands for substituting Blinatumomab to improve MRD eradication. And I think this is quite groundbreaking, as it completely replaces consolidation chemotherapy with Blinatumomab alone and the intensive pediatric protocol for de novo B-cell ALL in adolescents and AYA. And so perhaps as a start, you can explain, the hypothesis behind the substitution and why your previous study, which was ALL06, suggested this innovative approach was necessary to improve patient outcomes.
Sure. So firstly, thanks very much for the invitation and the opportunity to discuss the results of SUBLIME on behalf of my co-investigators and the Australasian Leukemia and Lymphoma Group, who were the sponsor of the study. So the original hypothesis is really all in the acronym, which was we had an agent which we knew to be very effective in relapsed refractory ALL, and we also had an agent which we knew to be extremely effective in the eradication of relapsed refractory MRD positive ALL. And we wanted to try and improve MRD negativity rates in our new study, because we had a previous study, ALL06, which was based on a pediatric study, which in and of itself was based on BFM 2000. We already had results from post-consolidation MRD from ALL6 that suggested that post-consolidation MRD is really a very significant predictor of both disease-free and overall survival. And so the hypothesis was, if we had a more effective agent that potentially could eradicate MRD to a greater degree and improve MRD negativity at time point 2, would that then extrapolate into improved survival? And based on ALL6, we thought that that would likely be the case. So by way of explanation, ALL6 was a study that was published in 2021, formulated with my colleagues Ken Bradstock and Luciano Della Posa. And it was a study in AYA ALL, so 15 to 39 years of age. using cytotoxics and based on what was called Study 8, or the ANZ Children's Hematology Oncology Group Study 8 protocol, which in and of itself was based on BFM 2000. That study enrolled between 2012 and 2018. It had a unique endpoint in that it was really designed to try and assess the tolerability of a pediatric protocol in an older age cohort. At the time when the study was being formulated, there was quite a lot of debate in the literature about what the factors were that determined what was historically poorer outcomes in adolescent and young adult ALL, whether that was predominantly the biology of the disease that was unique to ALL, or was it treatment tolerability, where we were trying to apply very intensive pediatric chemotherapy regimens in that age group. And so ALL6 was designed in such a way to try and tease that out and see whether or not that pediatric protocol was equally as deliverable in an older age group as it was in the corresponding pediatric cohort. And actually what it showed was it was equally as deliverable, and adult clinicians could in fact deliver a pediatric protocol in virtually the same time frame with the same proportion of patients proceeding to the next protocol block, which in this case was high-dose methotrexate or high-risk block therapy, as our pediatric colleagues could, which was a surprise to me as an adult clinician. I didn't think that would be possible, but clearly these protocols were quite deliverable. That then left the idea that really biology of AYA ALL was probably really the primary determinant of poorer outcome in this group. And subsequently, that's been confirmed by multiple other study groups. We see increased risk of adverse risk genomic disease in the AYA cohort versus the pediatric cohort. And that's probably the primary driver for increased relapse rates that we were seeing historically. ALL6 using a pediatric ALL intensified protocol still was associated with significantly better outcomes than we had seen historically. So 3-year disease-free survival was about 73% and overall survival about 75%, which was sort of double really what we had seen up until that point. The other significant finding from ALL6 was that the two primary determinants of disease-free and overall survival were MRD negativity at time point 2, post-consolidation, and BMI of greater than 30. And again, that really confirmed similar findings in multiple other study groups. The impact of time point 2 MRD had really already been demonstrated by the BFM group in 2010. We just extrapolated exactly their MRD assessment points. Didn't see much point in reinventing the wheel. If we were using a similar protocol, we should use similar MRD assessment points. And our study had similar findings to a much larger BFM cohort that suggested that really the MRD results were the thing that was really determining outcome more so than risk stratification and all the other historical markers that people had used prior to that. The BMI change was certainly the sort of thing that had been seen in other study groups, particularly some of the US cooperative groups, where poorer tolerability of these protocols seemed to have a significant impact in the poorer outcome in patients who were obese. But not only that, there did appear to be a bit of a trend towards higher risk genomic disease in patients with a higher BMI as well. So when we were looking to design a follow-on study, we were looking really predominantly at two things. We were looking at an agent that could provide us with a more powerful tool to eliminate residual MRD so that we had potentially higher rates of MRD negativity at time point 2. And we assumed that would then extrapolate into improved survival as we had seen in ALL6. And secondarily to that, but also an important consideration, was we were looking for an agent that would potentially be more tolerable and try to minimize the toxicities that we were seeing both in obese patients, yes, but also non-obese patients, where these protocols were still quite challenging for clinicians to deliver. And that consolidation block, which was sort of repeat dosing of cytarabine blocks, really bookended by cyclophosphamide and continuous 6-MP, that was quite challenging for clinicians to deliver. It was associated with high rates of cytopenia, lots of neutropenia, lots of thrombocytopenia. And we were hoping that we could incorporate new therapy, effective therapy into that block to try and improve outcomes overall.
Okay. So there's a couple of surprising things I find there. Well, first of all, I should say time point 2 in this case is day 79 for listeners who are wondering how long it is.
Yeah, day 79. So post-induction up from day 1 to day 33, and then from day 33 to day 36 really to day 79 is consolidation.
I like how you defined the AYA as 15 to 39 as a young adult, because that's really fantastic, because I'm just over 40 now. I was wondering when people define those, because it seems to be quite fluid about when they call, what AYA in adults. And I've seen pediatric studies up to the age of 30 as well. So,
and there is absolutely a bit of flexibility in the literature, but we really took on board what some of the larger cooperative groups were doing, particularly in the US, and they were defining their AYA cohorts up to 40. We'd gone up to 40 in ALL6, and that did provide us with a little bit of leeway, because the GRAL group had demonstrated that really beyond 45, trying to offer these very intensive protocols was really very difficult and often resulted in high rates of treatment-related mortality. So treating patients up to the age of 39 provided us with that 5-year buffer and a degree of confidence that we could deliver these protocols without too much in the way of excess treatment-related mortality.
Go on to the next question, which is about the actual how you set up the trial, and you settled on replacing that whole consolidation block with a 28-day cycle of blinatumomab as the course to take for this particular study. And you've reflected on some of that in terms of your considerations with toxicity, but there are a number of other studies that have also looked at putting blinatumomab in a more upfront setting, but they did it in combination with chemotherapy, I think. So how did you decide, well, we're going to just eradicate all chemotherapy? And was that within your study group as well? Did you have a lot of discussions about whether that was too risky to remove chemotherapy? Because that's the dream, right? Chemotherapy-free treatment. So maybe you can walk us through that.
Within the context of the study group, there was a lot of discussion about how to do this. So we knew that the BLAST study had shown really that blinatumomab was a very effective way of eliminating MRD. We had a prior study that had suggested that MRD negativity predicted for improved disease-free and overall survival. And we had already experience of the impact of consolidation chemotherapy, standard cytotoxic chemotherapy in this group. And we knew that was associated with about a 58, 59% MRD negativity rate at time point 2. In BLAST, we already had data that we could work with that suggested that a single cycle of blinatumomab in the MRD positive setting was associated with a 78% MRD negativity rate. So it really made sense to us in that context that we could hopefully effectively eliminate modestly effective chemotherapy regimen and incorporate what appeared to be an extremely effective immunotherapy regimen in order to improve a time point 2 MRD negativity. And we knew that time point 2 MRD negativity was associated with a significant prognostic impact. What we didn't know was whether that would extrapolate into longer term improved outcomes. I'm not sure we still know that. But we also had the added advantage that the standard consolidation blocks in BFM happened to be 28-day cycles with a 2-week recovery time prior to MRD assessment. And that phase 1 and prior phase 2 studies had established that a standard 28-day continuous intravenous infusion of blinatumomab was the standard dosing regimen. So we could really just incorporate blinatumomab really as a cassette. We could just remove standard cytotoxic blocks and then simply incorporate blinatumomab into exactly the same protocol. And we didn't really have to change the timing. We had to do minimal manipulation of the rest of the protocol in order to be able to do this. And subsequently, it just made sense really that if we were seeing high rates of MRD negativity with blinatumomab in consolidation, in the first part of consolidation, why not just extract cytotoxic consolidation entirely out of the protocol and just have 2 cycles of blinatumomab, which was the approach that we took when the study was designed in 2018.
Amazing. Very bold, if I must say, to do that, I think.
In retrospect, it does seem a bit bold, but I've got to say the approach of, and this was really serendipity more than anything, the approach of taking a second blinatumomab block and applying it in an MRD negative cohort, which is the way the protocol was designed, seems to have been borne out by subsequent study groups with publications of E1910 suggesting that there was a really very profound survival advantage in offering blinatumomab in the MRD negative setting. So it is somewhat serendipitous that our protocol has replicated that.
One of the things which you've already said as well is that blinatumomab is in the consolidation phase was really well tolerated, which is fantastic. And I must say, a close friend of mine whose daughter had blinatumomab when she was relapsed BLL said what a game changer it was for him as a parent, because it was, just so well tolerated for his daughter as well. And in this particular study, you also found that, but then it was associated with a more rapid progression to the next treatment phase. In this case, because then you split back to chemotherapy, either like an M phase or a high-risk block therapy. I'm not sure what exactly that means because, like the rapid transit to that. And so maybe you can explain to the listeners what that means in terms of the clinical management and the outcomes of the patients by having them quickly transit from the blina to one of the other protocols.
Yeah, sure. So in ALL6, we had used treatment deliverability as the primary endpoint. So we already had experience in looking at this. And we really wanted to assess whether or not blinatumomab, based on the findings in ALL6, whether blinatumomab would be more tolerable by using a sort of whole surrogate marker. And we used that surrogate in ALL6 to determine the primary endpoint. We thought we would do the same in ALL9 to provide some consistency between the two studies. And look, I suppose not unexpectedly, blinatumomab was associated with a greater proportion of patients proceeding to the next treatment block, protocol M or high-risk block, than in ALL6. And really a substantial shortening in the amount of time that it took patients to get to that point. In ALL6, we used day 94 as the target, the proportion of patients who were proceeding to the next treatment block, which in a BFM protocol is either high-dose methotrexate for CNS prophylaxis or high-risk block therapy if you're a high-risk patient, potentially leading to allogeneic transplant. We determined, our pediatric colleagues had determined that median time point by looking at a cohort of pediatric patients who were proceeding through study 8. And so day 94 was the median time point where patients were either proceeding or not proceeding to protocol M or high-risk block therapy. So we could take that secondary endpoint in this study and assess how tolerable blinatumomab was in terms of deliverability and how fast patients were proceeding through the protocol as a surrogate, really, not as a absolute marker of any given individual toxicity. And really it was, I think, fairly remarkable. Patients were moving into the next protocol block at a median of, I think, 13 days, almost 2 weeks more rapidly through ALL9 than they were through ALL at that particular time point. And there is some data suggesting that does have an impact on subsequent relapse and overall survival endpoints. In UK ALL12, this was looked at. And certainly for patients who had delayed progression through the protocol, there appeared to be an overall survival impact, particularly for those patients who were proceeding to transplantation primarily. But also, I think in terms of patient convenience, there is a sense that patients will tolerate this more reasonably than significant blocks of cytotoxic chemotherapy, repetitive cytotoxic chemotherapy. And while we don't have any data on this, I mean, as a clinician treating these patients, it's always reassuring to know that your patient will be proceeding through the protocol within a reasonable time frame, because the subsequent blocks of therapy typically have to be delivered as an inpatient. So you have to book the patient into your next protocol block, high-dose methotrexate or a high-risk block. Really invariably has to be administered as an inpatient. And the other more practical issue, I suppose, is just scheduling your time point to bone marrow, which, if you can be slightly more guaranteed that your patient will proceed through the protocol in a given time frame, it certainly makes it easier, I would imagine, to be able to schedule your bone marrow biopsy than it otherwise would if you were waiting for substantially longer to be able to have your patient recover from the block of therapy before proceeding to the next bone marrow. We don't have any data on that, but it certainly makes intuitive sense to me that would be a benefit of the protocol.
Well, you mentioned risk stratification, and I kind of want to challenge you on the fact that maybe the immune therapies are in a way upsetting the apple cart, because this is a point you also suggest in your paper, that inclusion of blinatumomab may impact the prognostic relevance of classical risk groups. And when I say classical risk groups, from a historical context, that's patients that have undergone standard of care chemotherapy and associate those with genomic subtypes. But in the era of immune therapies, we have this expression of CD19 on the cell surface, which is probably agnostic to the underlying genomics, which is driving the BLL, and perhaps the immune competence of that patient as well. Maybe that's related to the BMI, as you mentioned, of the patient associated with the sensitivity to Blina when they receive it. And maybe the sensitivity is agnostic to the genetic subtype. So, what are your thoughts on this, and how should clinicians use the genomic findings in the future to tailor treatment, given that if this is going to become up the front? Do they ignore that until you get to day 79 and then do the high risk? You kind of do this a little bit in the paper, but perhaps to get your thoughts on the role of the genomics in the era of immune therapies.
And I think the simple answer is we need more data.
Okay. Always more data.
More data and longer follow-up. But look, you're correct in that my feeling is that risk group stratification is based on standard genomics or standard genomic risk classifiers is all based on response to standard cytotoxic chemotherapy. And I think it's challenging in ALL to come up with individual genomic markers that help predict risk. Often these are quite small cohorts where people are trying to extrapolate prognostic impact of really multiple genomic anomalies in ALL. A lot of the data that we have is being extrapolated from pediatric cohorts, which may or may not apply in AYA groups and certainly may not apply to the same degree in older adults in particular. And the genomic mix is obviously quite different between pediatrics, AYA, and adult ALL, where you have an increasing proportion of adverse risk from genomics as these cohorts age. So I think that is challenging. The other challenging issue is that the risk group stratification is very much protocol dependent. So depending upon the type of protocol you're using, the time points that you're assessing response, the sort of agents that come before and after each assessment point, it does make risk group stratification quite individualized for each study group. And I think that can also be challenging when you're trying to come up with a universal prognostic algorithm. It's interesting that there's been a number of attempts at trying to look at the sort of relapse profile of patients who have been exposed to blinatumomab. There was a recent City of Hope study that was published, I think, at the beginning of this year, that assessed the impact of blinatumomab and the sort of profile of the patients who were relapsing subsequently. And interestingly, they found that still 2/3 of patients remain CD19 positive. Certainly, I suppose, to some degree, implying that there was an element of immune lack of responsiveness in certain individuals that might suggest that blinatumomab was not engaging the immune system as you might expect. And about 1/3 of patients were CD19 negative on relapse. And that interestingly, a significant proportion of those happen to be TP53 mutated ALLs.
Okay.
Which, look, I don't have the data on in our cohort yet, but we will certainly be assessing that in our next study. But the other cohorts that were associated with CD19 negativity were KMT2As, which we know to be an intrinsically high-risk genomic marker, as well as hypodiploid patients. In the context of our study, one of the interesting findings, I think, was, and again, we had very small numbers, so it is hard to make too much of this, but the PAX5 P80R mutated subgroup, which would ordinarily be considered a standard risk marker in cytotoxic in a chemotherapy-based protocol, certainly based on some pediatric data. In the AYA literature, it might be less standard risk, potentially. But in our patients exposed to blinatumomab, 75% of those patients remained MRD positive. And there has been some work looking at the PAX5 mutated subgroups and why they may not respond to blinatumomab in the way that you might expect an otherwise standard risk group might respond. And PAX5 appears to be an activator of CD58, and you require CD58 as a ligand for CD2 T-cell activation in response to blinatumomab. And the PAX5 P80Rs, at least in some PDX studies, I think Lee from maybe 2 or 3 years ago looked at some PDXs and mutated PAX5 P80R patients. They had the lowest CD58 expression,
right,
and were resistant to blinatumomab. So that does throw open a whole new paradigm of immune responsiveness, T-cell activation, the markers that determine the efficiency of your T-cell activation in response to blinatumomab and the sort of response that you might expect going forward. And in our patients, again, in our study, 75% of PAX5 p-ADRs remained MRD positive at time point 2. And so we had really converted what should have been a standard risk group of individuals into now what was considered to be a high risk group of individuals using what we thought to be a profoundly effective MRD eradicating agent. And so going forward in our next study, PAX5 p-ADRs are likely to be treated with standard cytotoxic consolidation and not offered blinatumomab. So I think going forward, there will be immune mechanisms that are determined that will assist in trying to prognosticate patients when being exposed to these agents, really very effective agents in the de novo setting. And I think that genomic risk stratifiers will change. What's considered adverse risk and standard risk will change. Philadelphia-like disease, for example, in our paper, again, these are small numbers. I did quite well in the study. They were all MRD negative, and the same with our CRLF2 patients as well. Again, typically considered adverse risk in standard cytotoxic regimens. And both Philadelphia-like and CRLF2 patients were 100% MRD negative in our study. The other important thing to note is that investigators were blinded to genomics in our study, so you only had access to MRD results. And so these patients were then just treated on the standard protocol unless they had some other clinical risk factor.
Okay.
And we didn't unblind investigators to the genomics until the patient had relapsed in order to try and help define targeted salvage regimens if they were applicable. So I think going forward there will be likely a change in the genomic classifications, but with the caveat that I think we need more data and we need longer follow-up.
More numbers.
The other issue that I really need to highlight is that what we're hoping, of course, is that the results that we've obtained in ALL9 will be durable in the longer term, but we don't have the longer term follow-up data yet to confirm that.
Okay. So if I can summarize, maybe it's almost like standard of care chemotherapy is cell intrinsic based. So it's the response by the leukemia cell itself, how they can cope with that. And yet the immune therapy is almost cell extrinsic. It's reliant on the ability of the immune system. So you've got two caveats there you need to be able to take into account. Okay, like the PAX p-ADR, for example, the cell intrinsic mechanism might make it standard risk to standard of care chemotherapy, but then the extrinsic immune therapy makes it a higher risk and vice versa. So you've got to start thinking about that in both. And you can't dissect those two completely in a way. You did mention a lot of the cases relapse with CD19 positive ALL from previous studies, the City of Hope, I think you mentioned. Is that something of concern for you as clinicians? Because if you've got this amazing immune therapy and chemotherapy or sort of standard of care chemotherapy for ALL has been such a success story in the pediatric setting in particular, and now you take blinatumomab, which was almost like the therapy of last resort to get them to bridge to transplant or alternative, and then you bring it up front and then you get a relapse. Does that mean then you lose something from your armamentarium if they relapse again? Is it a case of you go back and forth between immune therapies, cytotoxics, go back to immune therapies and cytotoxics and vice versa? Like, what are the things that you're thinking about in terms of those types of cases?
Look, it is a good point. And it's certainly been of concern to my colleagues, both in the study group and clinicians who are enrolling patients on these studies. If we're using such effective CD19 targeting agents up front, what happens to our salvage options at relapse? And I suppose the first thing to say is that what we're desperately trying to do is design protocols to avoid relapse in the first place.
Okay.
Longer term relapse outcomes in ALL remain very poor. So what all of the emphasis and really prioritizing therapies in AYA ALL, which I can speak to, has been about trying to minimize the risk of relapse. And with each iterative study, the relapse rates have been falling. And I suppose that's really the most critical thing. I suppose to some degree it's reassuring that in studies like those from the City of Hope, that 2/3 of patients remain CD19 positive, and so that allows access to CAR T cells targeting CD19. Most of these patients will remain CD22 positive, allowing access to inotuzumab, with the caveat that you have to be concerned about the risk of VOD if those patients are proceeding to transplant. And look, in the context of what we're trying to do in our next potential study, we're looking at targeted agents to try and improve MRD negativity prior to allograft that no longer relies on CD19 expression after you've been exposed to blinatumomab. There is some older data suggesting about a 30 to 35% response rate in patients who are retreated with blinatumomab if they remain CD19 positive. So it's not an absolutely hopeless situation by any means. There is some concern, particularly in the context of MT2A disease, I suppose, where there have been cases of lineage switching and where there's a much higher rate of CD19 loss of expression on relapse. And they're clearly very challenging patients to be able to deal with. In our next proposal, we're hoping to try and use menin inhibitors in those patients in the MRD positive setting in order to eliminate residual MRD prior to allograft is the current plan, no longer relying on CD19 expression to induce a secondary remission.
Because I was going to ask that as one of my last questions, is about what the next plan is, and you've already alluded to that you're going to add targeted agents like menin inhibitors. Any other agents that you're considering? Will that be like TKIs, tyrosine kinase inhibitors? Then will be matching genomics, expression of certain genes, maybe RNA-seq. And does that mean fuse RNA expression, for example, or is it just going to be based on the genomic or the presence or absence of mutations?
So there's already RNA-seq built into the current protocol.
Excellent.
Where it will differ from the protocol from ALL9 is that clinicians will have access to their genomic results and RNA sequencing up front. Yeah. So in real time, in that typically by the time we're getting to consolidation, most of those results will be reported to clinicians. And we're hoping to use those results together with MRD responses to build a more dynamic risk stratification algorithm throughout the lifetime of the next study, rather than having these very fixed stratifiers up front and then retrospectively going back and saying, oh, well, that risk stratifier no longer applied. We want to try and capture these changes in real time and adapt the patient's treatment approach during the lifetime of the study, which is one change that we're hoping to incorporate into the next proposal. The second one is what to do with patients who remain MRD positive at the end of their blinatumomab consolidation. Those patients have tended to do worse, though not significantly so, except in the adverse risk genomic subgroup where there was a significant reduction in disease-free survival of 70% in that cohort versus 100% in the standard risk group. So for those patients who remain MRD positive, which generally speaking were adverse risk genomic patients, those patients will now proceed into a phase 2 sort of platform study where arms will be determined by targeted mutations. At the moment, we have 3 arms, only one of which is really targeted, and that will be the menin inhibitor arm, so using revumenib in KMT2A disease that remains MRD positive, and the majority of our KMT2A patients remained MRD positive. And for those patients without an obvious target, where we don't have a target available at this point in time, they will receive a venetoclax-based combination. And there's, again, good phase 1 data suggesting that venetoclax is fairly effective in the relapse refractory both B and T cell phenotype. We're including T cell phenotype in our next study. So we're hoping that might have an impact in the MRD positive space. And then for those patients who have very high levels of MRD through the course of this adaptive protocol, we'll take those patients off early for CAR T cell therapy if their MRD is greater than or equal to 10 to the minus 3. And again, we're hoping for those patients that we'll see significant improvements in MRD response and almost lapsed or refractory disease, really, when your MRD is getting to be greater than 10 to the minus 3. But we'll only intervene with transplant for those individuals if we lose B-cell aplasia or they become MRD positive or remain MRD positive after CAR exposure. The endpoint to the platform design is MRD negativity rate prior to proceeding to allograft. We don't think that we can confidently exclude allograft in most of those patients who remain MRD positive following exposure to blinatumomab. Not at this point.
Yep. I like how you're going to include the menin inhibitors. We had Olaf Heidenreich talking about the use of menin inhibitors and FLT3 inhibitors in KMT2 arranged, or not 98 rearranged AML patients actually recently. And you would have seen those two big papers from Charles Mulligan's group and Mark Dawson's group, where they've actually got the KAT6/7 inhibitors with the menin inhibitors to overcome menin mutations. So even in the event where you have a menin inhibitors and they get mutations, there might still be another salvage option there as well as these KAT6/7 inhibitors, which are being used in ER-positive breast cancer are coming through. So that's quite exciting.
The data to date is really all in the relapsed refractory setting, all in the morphologic disease setting. So we're hoping that in the MRD positive setting, we may see, or we assume, either equal or improved efficacy if we're trying to eliminate low levels of MRD, because almost invariably these patients moving into the platform post-consolidation will be in remission. That was certainly the case in just the standard cytotoxic ALL6 study, and even more so the case in ALL9, where almost all patients are in remission at that point.
Okay, well, I've got one last question for you, which is about the story of the paper. Were there any unexpected challenges and surprises along the way? And perhaps you can give any advice to other motivated clinicians around the world who might also want to carry out a similar size trial. Any insight that you can give to people?
A similar size trial. Well, I suppose the first thing to say, Charlie, is this is actually quite a small study.
Yes.
In many
that's
respects,
why I wanted to highlight that, because it's like people would think I've got to enroll 1,000 patients, and I think you have 55 patients on the study.
55 patients in the end. Look, really, there are challenges in the local context. Australia has a relatively small population in a very large land mass. So studies are expensive to run in this country. We don't have extraordinary populations in close proximity, so the logistics can be quite challenging. Transport costs are very high. And that was particularly the case with these studies where we're looking at individual centres that can perform the analyses for us that clinicians require to be able to proceed through the protocol. So MRD, ASO-PCR-based MRD was only available in one centre, as you're aware, in Sydney. And genomic analysis was based in Adelaide, and we had 15 centres across the country that were enrolling patients. So there were logistical challenges involved in getting samples from Perth to Sydney and Brisbane to Adelaide and whatever. But we'd already in ALL6, we had a precedent for doing this. We already had a really excellent collaborative framework that made this work, really, despite all the logistical challenges involved. I suppose one thing that was a bit of a challenge in the current study was we relied on ASO-PCR MRD as our MRD technology of choice, and we didn't have an alternative approach to assessment of MRD in the study. We thought that would be beneficial in that we had a Euro MRD accredited facility in Sydney that we could use. And we had also used ASO-PCR and ALL6, which not only made for a degree of internal consistency, but also allowed our international colleagues to be fairly confident if they were using ASO-PCR MRD that they could expect similar results. But what that also meant was that we had about 10% MRD failures in the study, so that we couldn't identify an MRD marker. We hadn't really allowed for flow, for example, or KMT2A specific based PCR, and NGS MRD was just becoming available, but we didn't have a lot of experience with how to incorporate those sorts of results in this kind of study, or what the correlations were between ASO-PCR and NGS at the time the study was formulated. So going forward, of course, we've been able to incorporate NGS MRD now, KMT2A specific MRD monitoring, and we'll also incorporate flow so that we should be able to minimize the number of patients who were MRD failures. It meant that we had to enroll higher numbers of patients in this study than we were anticipating, because really the endpoint was determined by what was called a modified intention to treat population, which had to have informative MRD markers. Otherwise, we couldn't assess the endpoint. And you also had to get to the point where you were receiving Blinatumomab. So those things were slightly challenging in the context of the study. As usual, the submission process is often difficult and challenging, but provides new insights, giving you a new perspective on the sort of problems that you hadn't really foreseen in the writing of the manuscript. none of that's particularly surprising. In terms of advice for other clinicians considering generating concepts for clinical trials, I suppose the first thing to say is it's really important to have a really good team that you work with in terms of your co-investigators, in terms of scientists, correlative scientists who are providing some of the information you need to design your next study, and clinical trial coordinators and clinical trial sponsors. In both ALL6 and ALL9, I was fortunate to work with incredibly motivated, enthusiastic clinicians and scientists and a study sponsor that really made the whole process reasonably straightforward. I suppose the other thing to say is this is particularly challenging in the Australian context, where small populations, very large landmass, very expensive clinical trials. It's really important to try and have a novel concept, a novel study design that might attract the interest of peer review funding support and pharma support. And that's particularly now, as you would be well aware, it's quite challenging to attract peer-reviewed funding support, really quite difficult in the current environment. So you do need a study concept that is novel and that will be attractive to peer review funders and also to your pharma colleagues who are obviously looking to try and develop trials that will support registration indications as well. And then I think lastly, it's really important to persevere. These clinical trial concepts don't come out fully formed. There is a lot of negotiation, a lot of backwards and forwards, a lot of changes to study design and protocols until you come up with a formulation that works for most people, your clinician colleagues, your scientific colleagues, pharma, if they're involved in supporting the study, peer-reviewed funding agencies. But, I think it's critical that if you have a concept and you think it will improve patient outcome, it's really critical to persevere.
Yep, absolutely.
In order to make this stuff happen. Clinical trials are challenging. It's very challenging to go from a concept to a successful completion of a clinical trial. It's challenging then again to have it published. And it takes a lot of perseverance to be able to make this happen and the support of your colleagues.
I think just a few points there. Like, it's kind of incumbent on us to try and reach zero. You said before, we want to avoid relapse. And I think I went to a talk from Mignon Lo. She was saying, we've done so well with ALL pediatrics, 99%, but really the challenge is to get to 100%. We want it to be completely curative. So that's the first thing. So I think, as you said, we want to have these clinical trials to push that. And I really appreciated when you said that, when it's like, well, we don't want to often think about relapse because that's exactly what we want to try and avoid. Also, the distance. I mean, people who listen to this, they'll go, I don't understand what Brisbane to Adelaide is, and I had to type it up quickly. It was 2,000 kilometres, by the way. That's how late. So in the European context, I'm trying to work out, there's distances, and I think it's, if you go from Adelaide from Perth to Sydney, I think it's, the same as going London to Moscow or very similar.
Yeah. So sort of 5,000 Ks or something.
You can imagine people who are trying to get samples to certain points. There's time, there's flights. It can be hot.
Yeah.
All the samples be okay when they arrive. Is there enough dry ice if there's a flight delay, etc.?
Yeah, so absolutely. And the logistics involved in that sort of study in a country like Australia, is particularly challenging. A lot of those logistical issues had really been resolved in ALL6, and so the transition into ALL9 was much smoother. Excellent. It was no cheaper, unfortunately, but it was certainly much smoother.
Yeah. And I think as well, your point about grant funding, and this is true. Australia is getting more and more difficult to get research funding. I think the same is true for our colleagues in the US who are having a lot of trouble, and even Europe as well. So we really have to advocate for big team science. And in terms of the peer review for HemaSphere, I think you're supposed to say how wonderful it was, right? For our want to streamline, but this is part of the process.
I've got to say, my peer review colleagues really were quite insightful, as is often the case.
Yep.
And taking their comments on board made for a stronger paper. I don't think there's any doubt about that. And it certainly resolved, again, for an external audience, it resolved some of the issues at play that people really wanted to understand more fully, to be able to take on board your final messaging, which is we can incorporate Blinatumomab early in de novo AYA-ALL and potentially see a superior outcome. But the results from this paper really are an indication of where we should be going forward, rather than the result in and of itself. It's an indicator that we can potentially safely eliminate blocks of chemotherapy as long as we're incorporating very effective alternative agents, which in this case are CD19 BiTEs.
So I'll stop there, but I'm going to ask one question. All clinical trials have amazing acronyms. Your one is SUBLIME. You're going to have to think of a new one. I don't know any advice on did you put that in ChatGPT and say, this is what we want and we want to have a nice acronym? Or was it like a serendipitous, like it just came out? Because you're going to have to think of a new one. So
sadly,
what's the secret
Charley,
to a good acronym?
This will age me terribly, but at the time when the study was being formulated, there was no such thing as ChatGPT. So, look, I will have to admit, hand on heart, I did put that into a acronym generator.
Okay.
But, acronym generators are like most things in life. The quality that comes out is only as good as the quality that you put in.
Okay.
So it did take a few iterations to come up with SUBLIME.
To shoehorn the words.
That's right. Not sure I'll be able to quite top that going forward. But,
well, I guess it's SUBLIME 2, or would probably
maybe.
At
one point, I think we'd come up with, as a study group, we'd come up with SUBLIME Novel, and that was the next iteration. But like so many of these things, novel or novell sort of fell over, and we've had to change it to an alternative acronym.
Excellent. Well, thanks, Matthew, for the wonderful discussion. Congratulations to you and the entire team, the ALLG team, for the publication at HemaSphere. And we look forward to perhaps the next iteration, and perhaps we can have a discussion when the results come out in a few years for that one, or however long it takes.
Hopefully that will be the case.
Yeah, wonderful. Thanks, Matt.
Thanks, Charley.
Thank you for listening to this episode of the HemaSphere podcast. All of HemaSphere's content is open access and can be found at www.hemaspherejournal.com. We hope you will join us for future podcast episodes.